prepare into live stream.
Thank you. Good morning, everyone. Welcome to the Health and Government Operations Committee, to the Public Health and Minority Health Disparities Subcommittee. As you know, we meet every Tuesday immediately after session. So even if you do not get the notification by text immediately after session, please log on. Erin Hopwood, who is the legal counsel for this committee, sent every member the bills that we have on the agenda today. She sent the amendments, and instances where we had the interlineated copy, she sent it to you. She's very good about that. You always get it ahead of time. And if there's any questions, she always tells you to contact her. Don't wait till the day that we have the hearing. There's no excuse because you get it ahead of time. Today, we have the following bills. We have House Bill 611 will be first, 643, then 849, then 1243, then 1148. The last will be 463. We're going to hold House Bill 1280, committee members, which is actually the Maryland Community Health and Public Safety Center for Excellence bill. It's my bill because I want to make sure that the amendments that we have are all the amendments we should have, and that it mirrors the Senate. So we'll be bringing that to you at the next meeting. But you have the paperwork, you have the amendment, you have everything you need on every single bill. So let's start first with House Bill 611. If there are any advocates here today that are on 611, you will get an opportunity to speak as well. So Erin, please describe the bill for us.
This bill prohibits a manufacturer beginning July 1st, 2022 from selling or offering for sale in the state a cosmetic if the manufacturer knows or reasonably should have known that the final product or its individual components were developed or manufactured using animal testing conducted on or after January 1st, 2022. The bill establishes many exemptions to this prohibition, and a local law enforcement agency may enforce the bill, and the state's attorney for each county may seek appropriate relief for violations of the bill. The bill takes effect January 1st, 2022. This bill was voted favorably out of the subcommittee, went to full committee, and it's been returned to subcommittee to answer some questions that Delegate Riley had during the full committee voting session.
Yes, and the last time we were here, I know the last time we spoke in full committee, Delegate Riley brought up companies like Avon, companies like Mary Kay, which in fact, they do not test at all. So the information was not correct. It's wrong because they do not test, and they're very specific about that as well. There's also, for the committee members, there is a letter from the Maryland Retailers Association where they wrote, and we sent that to you, where it says, Chairman Pendergrass and honorable members of the House Health and Government Operations Committee, our organization has reviewed House Bill 611 and decided not to weigh in on the legislation as we do with most bills that do not impact our membership. Upon reviewing 611, our association feels the language found on page 2 of the legislation protects retailers that may partner with manufacturers to private label items or even purchase them from a manufacturer and then put their own label on them. We have used similar language about knowingly selling items in various bills and areas of the code to ensure especially smaller retailers are held harmless. And then they go on to cite the language that they are actually happy with. Any questions or concerns regarding this bill?
Madam Chair, I think it was Delegate Riley who held it. Perhaps, Delegate Riley, are you satisfied?
We can't hear you. You're muted. You're muted, Delegate Riley. You're still muted. Edith, are you able to unmute her? I know, Delegate Riley, you're not able to unmute yourself? We can't hear you.
Yes, sorry. All my bottom toolbar was completely gone, so I had to minimize the Zoom call to find it. Yeah, I do appreciate the letter from, that does help, the letter from the Maryland Retailers Association. I still have a hard time, bill to where nobody can tell me if there's no business. Now, I understand the Maryland retailers are saying none of their membership have a problem with this, but the bill itself, to pass something and not to know if it's affecting any businesses in the state of Maryland is just kind of, bizarre to me. And, one of the arguments for the bill was that, that most companies are already doing this. So I don't understand why we're put in a position to have to vote for something that's not necessarily, and if we can't find any business and that's a good thing. But why do we need it if there is no business affected by the bill? And the only thing we're passing is because we're worried about what China does. It just doesn't make any sense to me because we can't stop what China does anyway.
1 second, Delegate Riley. It says Delegate Shalega said the host has stopped my video. Please restart. Edith?
Back?
Oh, you got it? You got it. She got
I'm back.
it.
Somehow they clicked a button.
All right, no problem. No problem.
Yeah.
Go ahead.
So that was kind of my concern. I am happy that, you did reach out to the Maryland retailers, and it doesn't affect any of their companies that they support. But it still doesn't answer the full question of, what companies this does affect in the state of Maryland. And
So Delegate Riley, can you just give me a second and let the advocates address that, okay?
okay, thanks.
All right, so we can go in an orderly fashion. Thank you. For the advocates.
Thank you, Madam Subcommittee Chair, and thank you, Delegate Riley, for asking these questions. I think it is important to really understand what all these bills would do. We shared with the leadership of the subcommittee, and we also shared with you, Delegate Riley, a list of companies in Maryland that actually support this legislation, either through their participation in the Personal Care Products Council, PCPC, or because they independently put in written testimony in support. This includes about a half dozen, including Mom's Organic Market, Lush, Jill Turnbull, which is a Baltimore company, High Tech Color, Discernis. There's a few others on this list, and we're happy to share it with the full subcommittee. What we know is that the manufacturers actually want this legislation because it will accelerate the rate at which we, as a state and therefore as a nation, are shifting to animal cruelty-free products. It also gives them consistency and clarity. So this is a bill that is actually something that the PCPC, that manufacturers industry, wants to have on the book so that there's consistency across these different states, and we're building towards a consistent national platform. And it's not about China, it's about accelerating the rate of shifting to cruelty-free here in Maryland and really rewarding our companies such as the Cody company, which is based in Maryland, that have been making this change and have been ahead of the game, because those companies want to see a level playing field and they want to see others being held to these same standards.
All right. To follow up with that, can I follow up, Madam Chair?
Absolutely, absolutely.
Okay.
That's what we're here for.
So also within the bill was another thing that we don't have any information on what type of animals were used in the testing currently. And, the percentage, I mean, are we talking about lab mice? Lab mice? Are we talking about guinea pigs? Are we talking about cats, dogs? So it's just a lot of information.
Let's let the advocate answer it. Okay, go ahead. What types
Thank you
of
again. So we see a wide variety of animals used. We see rabbits, guinea pigs, rats, mice are sort of the most commonly used animals, with rabbits having sort of the longest history of being tested on. And what we found, to address some of the concerns that were raised in the full committee, is that testing on these animals actually does not provide a very clear indicator of how a product is going to impact human physiology. So what these companies who really knew the way have done is they've switched to lab-based testing on humans' cells that are cultivated and grown in labs. That actually gives us more certainty that human health won't be impacted. Although we have, again, this unfortunate history of testing on rabbits, guinea pigs, rats, mice, those animals do react differently to products. So this is also a sort of a public health. It's very rightfully in this subcommittee, because it does keep people safer to make sure that we're doing testing on cells that react the same way human cells will react.
Okay, one more question, just one more
Absolutely.
question, and I'll be done.
Absolutely.
So these same animals, are we currently using those to test other things like, like medical, like prescription drugs and things like that? Are they still using animals to test for those?
Yes, and testing on
Yes.
animals is not impacted by this legislation. Obviously, there was some incredibly innovative human cell-based testing done even as recently as around the COVID outbreak and making sure we understood how COVID impacted people. But this legislation only looks at cosmetics, and it doesn't even include some of the products that were mentioned last in the full committee, such as anti-aging cream. Anything that's classified as a drug by the FDA would not be included in this legislation, because we do understand there's a balancing act to be found between human health and making sure that the full array of testing is available for things that, are of critical human health emergencies.
And that
Okay.
will make Delegate Shalega very happy, right, Delegate Shalega? Because her cream that she wants for anti-aging, and I used to, they can still continue to test because it's considered a drug. I have learned a lot.
Many of us are using that. Even a lot of sunscreens and many of the other cosmetics are not classified as cosmetics by the FDA. And just wanted to echo that when you have the industry on board with this kind of legislation, they feel that it's a wonderful win-win because they attract new customers. It's great for their business, and they feel like they're doing a public service for animals. So, and then as we go state by state, then hopefully, the whole country comes into play in terms of passing this kind of humane legislation, which is, a way a lot of laws are passed state by state, just to address that question.
Okay, thank you, Madam Chair. And
Delegate
thank you.
pleasure.
Chisholm has been waiting.
1 minute, 1 second, please. 1 second. Next, we have Delegate Chisholm, followed by Delegate Bagnall, followed by Delegate Shalega.
Thank you, Madam Chair. I actually have two questions, and the first one's for you. You said it holds, there's somewhere in the bill on page 2 that says that they're held harmless. Did I misunderstand what you said? Because I was looking for it and couldn't find it. You spoke to hold harmless somewhere.
Oh, what happened? This was the legislation, actually, the letter written by the retailers, where it says that that they have used similar language in other bills, but there is a provision, if I'm not mistaken, in here.
Delegate Panamanic, I know where it is.
Yeah, I'm looking for it. It's in the bill.
Page 2,
Yeah.
lines 18. If you start on line 18.
Yep.
Oh, it says, except as provided in subsection C, this is what I was looking for, of this section beginning July 1st, 2022, a manufacturer may not sell or offer for sale in the state of Cosmetic if the manufacturer knows, so that's knows, or reasonably should have known that the final product or any individual component of the final product was developed or manufactured using animal testing. So that language is in there. And that's similar. We use similar language.
So if a manufacturer was doing it, they could plead ignorance, is I guess part of my question, because they could say we didn't know. I don't know how you prove that, but that's
right, because you
That's
should
for
have
the
known.
trier of fact.
Yeah.
Yes.
So my follow-up on it is, if this bill was law today, because this is what I'm having a hard time wrapping my head around. If it was law today, how many violators, and I know it's hard to pinpoint a number, would there be in the state of Maryland? So is there that many manufacturers and that many retailers using these type of products currently, or is this bill just going after a very small few?
Jennifer,
Thank you. So because
pleasure.
the testing that these companies do is proprietary, and it's very important to understand that their testing and their methods of testing are their trade secrets. And that's why we can't answer some of these questions with a certainty that we'd love to be able to answer them with, to Delegate Riley's concerns about not knowing the full scope of impact. What we know is that many of our large manufacturers have pledged to go cruelty-free, are cruelty-free, and are supporting this legislation. How many other companies are going to have to change their practices in the state of Maryland because because it is a proprietary, it is trade secrets, we can't say with certainty. But what we do know is that the manufacturers who are sort of leading the way, doing the right thing, who have gone cruelty-free, these companies want to see this legislation passed in all 50 states. They want a level playing field, and they want to see this sort of become the law of the land. And so while we can't say with any certainty, how many companies are going to have to change their testing practices, we do know that this is something that the industry as a whole supports and wants to see moving forward.
So if this were to become law, then those proprietary secrets would be then unveiled. Am I correct on that?
No, the law does not change. Absolutely not. We're not changing. There's nothing in the bill that changes that.
Okay, thank you, Madam Chair.
My pleasure. Delegate Bagno.
Thank you, Madam Chair. And thank you to the advocates for being here. I think in this committee, we often ask the question, what problem are we trying to solve? But this bill, as I read it, isn't reactive, it's proactive in support of the direction the industry already wants to go and the work that the industry is already doing. Is that correct?
That's very fair assessment. This bill accelerates a process that is happening due to market forces, but it will ensure that that process happens at an even faster rate because the states are requiring it and we're not just relying on the free market alone to get us all the way there.
And if I could just jump in a little bit to what Delegate Chisholm and what Delegate Bagnall are saying. This bill, it may not be that there are so many companies that are testing on animals, but it also is proactive in the fact that it tells other companies, we don't allow companies to sell cosmetics that tests on animals. It puts that benchmark up there. It levels the playing field. We have the support from industry, and it's also good public policy and where we should be moving in terms of humane treatment of animals and the best substitutes in terms of a public health standpoint, using artificial human tissue, as many of the companies have, as opposed to animals whose skin has fur and they have to shave it off. So one also has to wonder in terms of testing how good a model that often is.
Thank you, Madam Chair.
My pleasure. Delegate Shalega.
Thank you, and I'm glad to hear that my anti-aging cream is not included in this. But along that line, how about baby cream? Are they also separated like butt cream? My little granddaughters, I'm hoping they're not testing that on humans. Are they, is that in a separate category as well?
It depends on the ingredients in terms of the baby cream.
Yeah, I'll verify
just
for
regular
you.
moisturizer, that's one thing, but oh, go ahead, Jen.
Like diaper rash cream.
Yeah, I know exactly the cream you're thinking of, Delegate. We actually have some.
I think it's called butt cream.
We still use it in this house, even though I don't have babies anymore. I can verify that for you and let the subcommittee know. It is interesting. So many of these products, sunscreens, anti-aging creams, are classified as drugs, not cosmetics. My gut is telling me that those diaper creams are also classified as drugs because of their use, but I will confirm that for you.
And see, I'm aging myself because the creams that I used on my kids probably would not be drugs. So, but I'm using the anti-aging cream.
Okay. We have Delegate Riley again. We can't hear you. You're muted. Sorry, you're muted.
I know, I'm sorry.
It's okay. It
sorry.
happens to all of us. It's the
yeah.
Zoom world.
I said I fibbed. I said I was done, but after that conversation, I did have another question because I remember last time I brought up the bill where it refers to the article 700.3 and what was the other 701.12, and so now I'm back to my confusion.
So so Erin has an explanation about that. So she sent it to us. Erin, you want to go through that?
Yeah, because it said the only thing that was taken out was soap, and all these other things that we're talking about were in it. So now we're hearing that some of these creams, they're considered, prescriptions or what have you. So
I was going to speak
the difference
to the part of the bill about the labeling. Now you're referring to the ingredient.
Yes, let me see if
Okay.
700.3 or 7, where it says that all cosmetics, anything that's exempt from cosmetics was soap. Everything else that's put on your body, from lotions to perfume to colognes to, sunscreen, all of that is within Article 700.3 or 701. I forget which one it is, but
That's related to an ingredient. So that only refers to when an ingredient is stated in the bill, not a cosmetic.
well, ingredients are in cosmetics, right?
They can be part of
And
cosmetic, correct?
it says
But I
the
think what
definition
the
of-
point the advocates are making is that if like say the aging cream is classified as a drug, then it's not a cosmetic, and they're shaking their heads, so I think they can.
So
So
the
it's just an aging
the
cream.
FDA classifies certain items as drugs. So that does include your sunscreens, your anti-aging creams. So if the FDA classifies something as a drug, then that is how it is treated. These other items, your lipsticks, your blush, your concealer, those are what is sort of classified by FDA as cosmetics.
And if it's classified as a drug by the FDA, which they make that decision, then animal testing, they can do animal testing, and that is decided by the FDA.
Correct.
Right. So,
Correct.
so
This
that-
does not
This bill
impact
is not
the testing
changing
on
that
any
law.
of them.
It is
Correct.
Yeah,
not
this
changing
bill
the
doesn't
law.
touch that.
right. So I'm glad some of the items, because it was real broad. So I'm glad some of the items are taken out. And you had mentioned some like sunscreen and things like that. What about like, body wash or body?
Depends on the ingredients again.
Again, if the FDA classifies it as a drug, they're the ones that decide, not the state, then animal testing can be allowed. It is up to the FDA.
Right, but some of those, I'm assuming that the majority of the ones that we've mentioned will not be considered a drug, except for the aging ones, but that's okay. Thank you for answering my question.
My pleasure. Any other question? Shalega, is your hand up again, or you forgot to put it down? You forgot to put it down? Okay, great. Any other questions on the bill? This has been a great process. I can teach a little class on cosmetic now, animal testing. You had us doing a lot of reading, and this is wonderful. I really appreciate it. Are there any other questions regarding the bill or concerns? All right, seeing none, on the bill as amended.
Madam, it was already moved and
It was-
passed out of committee, so this
I'm so
was for
sorry.
clarification.
Yeah, this was for clarification. I am so sorry. It's been a long month. Anyway, we did vote on the bill, and we can take it back to subcommittee, to whole committee. Delegate Barron will be defending the bill on the floor. Delegate Barron has been taking copious notes and will be ready to address it in committee.
And
Okay.
I've got some nice pancake and eyeliner for him to wear when he.
Anyway, thank you so
all
much. Thank you for the advocates for being here. Thank you for doing the research. I know we had you sending us a lot of links and stuff to read. Thank you, Erin, for a wonderful summary and looking into the federal law. Delegate Riley Chisholm and Delegate Shalega, thank you for your questions. We really appreciate it. Now we're going to move on to House Bill 643, which is Cosmetic Product Ingredients Prohibition. Erin, 643.
So this bill was held last week during the subcommittee for the purposes of an amendment that is being offered by Delegate Barron that would add a knowingly requirement to the bill. So the bill with Delegate Barron's amendment would provide that a person may not knowingly manufacture, sell, deliver, hold, or offer for sale in the state a cosmetic product that contains these 12 intentionally added ingredients that are listed in the bill. There was also an amendment from the bill sponsor that provides that it's the intent of the General Assembly that the act be construed in a manner that is consistent with the prohibition on the presence of the same intentionally added ingredients in cosmetics enacted by the European Union.
Wonderful. Delegate Barron, would you
I'd like to move the amendments, both amendments.
Move the amendment, and may I have a second?
Second.
Any discussion on the amendment? Delegate Barron first, would you like to be heard?
This just adds kind of a mens rea, so that this is not a strict liability, if.
Okay, thank you.
Froze.
You froze. Are you, can you hear
Yeah,
us?
he's frozen.
He's frozen. 1 second. Delegate Barron, can you hear us? Well, why don't we just go to questions while Delegate Barron gets back with us. Delegate Barron, if you could hear me, you're frozen, and I'm going to go ahead to a question and I'll come back to you. Thank you. Delegate Chisholm.
Thank you, Madam Chair. Actually, before he froze, he answered the question. I just wanted to clarify that it's essentially an extra layer of protection.
It is.
Somebody unknowingly selling one of these products.
It
And
is.
I think it's similar to the language in the previous bill.
Thank you. Delegate Shalega.
Thank you, Madam Chair. And I think I'm gonna support this bill, but I feel like it's the poster child for something that should have happened next year. Doesn't take effect for 4 years. I just, with COVID, I just don't think we should be doing this kind of bill.
Well, I understand your concerns, but it is already drafted. It costs like $2,000 to draft a bill. The industry wants the bill. We have worked and spent some time on it. So, we might as well get it done. But I appreciate you and I appreciate your concerns.
Yeah, I
And,
don't think the industry wants the bill. The advocates want the bill. I think the industry's being nice, but that I would.
But you know what, Delegate Shalega? When the industry doesn't want a bill, they come in like 20, 30, 50 people and they start, protesting against the bill. We hear from them. So if they didn't want it, trust me, we will hear from them. I had a bill this past Friday in another committee that will not be mentioned, where the industry doesn't want the bill and they were like 40 against little me. So so they certainly get a chance to be heard. But I hear you, I do. And because of your concerns and Delegate Chisholm, Delegate Barron went ahead and drafted the amendment. So it's a stronger bill. And I do welcome your concerns and I'm very grateful for it. Thank you so much. Any other questions? Seeing none. Did we move the amendment? We did. The bill as amended, may I have a motion?
Move the bill as amended.
Second, both
It's been
amendments.
Moved and second. Any discussion? All those in favor say aye.
Aye.
Any opposed? Okay.
I'm going to be opposed. Shalega opposed.
Okay, Delegate Shalega. All right, thank you so much, Delegate Shalega. Thank you very much. So let's go on to House Bill. The bill passes with 1 opposed. House Bill 849. Erin, can you tell us what the bill does?
So there's a reprint of this bill that was distributed. It was heard last Tuesday, and the bill is amended. If you look on page 3, the bill now is essentially starting on line 17 is the bill in its entirety. So the bill would provide that a healthcare provider or a representative of the healthcare provider may not charge a fee for providing copies of a medical record requested by the patient's personal representative, or an employee or other representative of a nonprofit legal service entity, or other volunteer or nonprofit program representing the patient. And that will be used for the purpose of filing a claim regarding or appealing a denial of Social Security, disability income, or Social Security benefits under Title II or Title 16 of the Social Security Act. There were no opposition to the bill with these amendments.
Thank you. Are there any questions from the committee? Any concerns regarding
Move the
this?
amendment.
All right. May I have a second, please?
Second.
Second.
Okay, but wait a minute. Delegate Shalega, I didn't see you. Go ahead.
And just to be clear, this is reducing fees, correct?
Prohibiting fees.
Prohibiting
Yes.
charging a fee.
Thank you.
Thank you for the question, Delegate Shalega. Any other questions? Seeing none, it's been moved in second on the amendment. All those in favor say aye.
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 Any opposition to the bill that will prohibit fees? Seeing none on the bill
Move the
as
bill.
amended. May I
Second.
have a second? All those in favor, actually, are there any discussions or concerns regarding this bill? Seeing none, all those in favor say aye.
Aye.
Any opposition? It's unanimous. If I misspeak, will you be so kind and raise your hand if I don't see you, please? Because I don't have, here on the side, I can't see everyone at once. So I apologize ahead of time if I don't see you. Next, we have House Bill 1243. Erin.
So this bill was heard last Tuesday. There are no amendments. The bill modifies and expands the required contents of the Director of the Behavioral Health Administration's annual report on behavioral health services for children and young adults in the state. The bill also requires additional specified information to be included in the Social Services Administration's annual report on voluntary placement agreements for children and young adults in the state. The bill would add, in addition to certain services, outpatient services and substance-related disorder program services. There was no amendments offered and no opposition at the bill hearing.
And for the committee, there was just an impressive list of stakeholders. As Erin said, they were in support and no opposition. Are there any concerns that the committee has regarding this bill? Any questions that you may have regarding this bill? Anyone? Seeing none? Actually, Delegate Riley. I can't hear you.
Got it.
Okay, it's okay. It happened.
Yes, I had on my folder, this expands, so basically anything this is doing is expanding the behavioral health reporting for children and young adults. Is that all that this bill is actually doing?
Yes, it says when reporting on specified public health, behavioral health services, BHA must include outpatient services and substance-related disorder programs. And when reporting on the length of time children and young adults spent in specified location, they must use the median length of time as opposed to the average length of time. And then when reporting on children and young adults who were readmitted, they must report the number who were readmitted within 30 days.
Gotcha.
And then
Yeah.
the annual report must also include the number of children and young adults admitted for residential treatment centers.
Okay, all righty, thank you.
My pleasure. Any other questions or concerns regarding the bill? Seeing none, may I have a motion on the bill?
Move the bill.
May I have a second? Thank you so much. All those, any questions? All those in favor say aye.
Aye.
Any opposition? Is unanimous. Thank you so much, committee, for your questions and support. Next, we have, one second. We are going to hold House Bill 1280 because I want to make sure that we have all the amendments and they reflect the Senate as well. So it's not messy when we finally discuss it and it's easy for you. I'm going to make sure that you get the interlineated copy as well so that you can see the amendments that have been incorporated in the bill so that you can be ready before the next session. And Erin, will you be so kind and send it to everyone, please? Once we get it, Erin is going to get in touch with the amendment office. So thank you so much. The last bill of the date is House Bill 463.
No, you missed one. Delegate Panamanic,
Yes.
1148.
Okay, I'm sorry. I did forget 1148. I apologize. 1148. Go ahead. Thank you for keeping me straight.
House Bill 1148 requires the Maryland Department of Health, in conjunction with the Maryland State Department of Education, to report to the General Assembly on a plan to transfer administration of school-based health center grants and any related functions from MSDE to the Bureau of Maternal and Child Health in the Department of Health by October 1st, 2021. By July 1st, 2022, the governor must transfer administration of school-based health center grants and any related functions from MSDE to the Bureau of Maternal and Child Health. The bill hearing on this was last Tuesday. I know that the department had some concerns. I believe they're on this call, and there are some advocates who support the bill on this call as well.
Great bill, move the bill.
We're going to
Discussion.
have some discussion on the bill. So why don't we is the department here? Okay.
Yep, we're here, Delegate. This is Heather Scheck from Governmental Affairs, and then I also have Dr. Cheryl DePinto with OPHI and Dr. Chu, who is with Maternal and Child Health. So we got everybody from every angle for you.
Oh, okay, I saw you guys. Wow, Shane even followed you
One
into your
second,
office.
Rosenberg,
Yeah.
Delegate Rosenberg,
Okay,
will you
sure.
be so kind and mute yourself, Delegate Rosenberg? Delegate Rosenberg, will you be so kind and mute yourself? Delegate Rosenberg. Edith, can you mute him? We don't want to hear his conversation. Can you mute him? Thank you, Edith. I appreciate it. Appreciate you so much. I apologize for that, but I'm sure he doesn't want us to hear his conversation. Go ahead. Thank you.
Yeah, thank you for having us. So the department, our main concern is that we're not, this will be new and we're not sure how it's going to roll out. And so we aren't positive that it belongs in maternal and child health. Currently, SBHCs are under OPHI. And so to prevent fragmenting the program, we're suggesting maybe just adding some broad language to allow the department to determine what unit it best should live with as we kind of work through it.
Robin Elliott.
So Robin Elliott here today on behalf of the Maryland Assembly on School-Based Healthcare, as well as the Maryland Nurses Association. Very much appreciate the department's observations. We would ask for the bill to be moved favorably as is. We think it's really worthwhile to try to align all the work going on in the Bureau of Maternal and Child Health, whether it is vaccinations or all the other asthma management, diabetes management. We would note that there is a report due from the department to the legislature. And that would be a good place if the department, upon reflection, really determines that it wants to recommend a different part of the department, that would be a good place to do that. And we would be happy to work with the legislature and, of course, revisit any recommendations of the department.
Mr. Pinto.
Hi, good morning, everyone. My name is Dr. Cheryl DePinto, and I am the Director of the Office of Population Health Improvement at the Maryland Department of Health. And I just want to reiterate what Ms. Scheck said about our concern related to fragmentation of the program, and just wanted to explain to the committee a little bit about our rationale for that. So as you probably know, school-based health centers are an expansion of the mandated school health services programs that exist in all schools. And as of right now, the school health services program rests within the Office of Population Health Improvement. And we have a very long history of working not only within the department across units on school health related issues, such as those that were mentioned previously by Ms. Elliott, as well as have had a long history of working directly with school-based health centers. And so from the standpoint of the department, having the school-based health center reside in a different unit is the reason why there would be fragmentation. I think that it would be very helpful for the department to have the opportunity when considering this issue of the plan for the transfer, for us to be able to make any type of administrative, staffing, and other programmatic related adjustments that would be necessary to be sure that wherever this program ultimately fits within the department, that it is appropriately aligned with the other school health and school health services related programs within the department. And there are a lot of things that the school health services program does, from making sure that standards related to school nursing align properly with implementation processes at the local level for school-based health centers. And in addition to that, we also are the ones that work with the issues around telehealth programs within school-based health centers, which is another consideration along with vaccinations and other type of chronic disease management. The school health services program is the one that develops chronic disease management guidelines for schools that are implemented on the orders of a school-based health center clinician, but is implemented through school health services nurses at the local level. So for all of those reasons, we believe that having the program sit within maternal and child health, while it's very important that school-based health centers align with that work, from an administrative standpoint, we just believe that we need to take a thoughtful approach on how to do this best by leaving that specificity in the bill out so that we can make department-wide decisions across all the units that would be impacted.
Robin.
Thank you, Madam Chair. Thank you, Dr. DePinto. You raised really interesting points. As someone who's worked in public health programming and program implementation, I get the concern, the anxiety about integrating programs. I get that. I guess I'm curious to know, I think this is a great bill and important, and we need to strengthen our school-based health centers. But I'm just curious to know, when you talk about fragmentation, it makes it sound as if there is no existing interaction between maternal child health and the school health services program. Fragmentation, are you saying it's going to make it worse, or it's going to introduce obstacles to partnership and collaboration and joint management? I just want to understand a little bit more about the culture and the structures.
Yeah, so right now, the integration of school-based health centers into school health services programs is done by coordination and collaboration with the Maryland State Department of Education, because they are the ones who currently oversee the school-based health center program. So all of that coordination and collaboration would be shifted from MSDE to maternal and child health. We already work very closely with maternal and child health on the school health services side of things, everything from vaccinations to mental health services within schools. We do that in the framework of school health services program. So when I'm talking about fragmentation, I'm saying that within the department, we'd have two mandated programs operating out of two different units that would create additional challenges around coordination, because it would require different staffing patterns in order for that to work, because we'd be getting a new program. So the new program coming over would create additional administrative processes and collaborative actions on top of what we already do now with MSDE. And it may be, I don't know if my colleague, Dr. Chu, would like to weigh in on that, but make no mistake, we work very well together. And it's just a matter of when you're taking on a new program, there are other administrative things that have to be considered by virtue of that in and of itself.
And so you're saying this bill doesn't support that collaborative transition? Is there something else you need?
From the standpoint that it does not provide for additional staff to be able to, to do that. So I would have Dr. Chu be the one to comment on that. But right now, the what I will say minimal staff for school health services resides within the Office of Population Health Improvement.
Thank you so much, Madam Chair.
Definitely. I was actually calling on Robin Elliott
earlier,
but that's—
I'm sorry.
It's okay. I have a couple of—
I did have my hand up, Madam Chair. I'm sorry.
It's okay. Thank you. I see the other questions now. I don't know, Robin Elliott, if you want to be heard before I go on to questions. I can't hear you.
So I'm honored to be mixed up with Delegate Lewis.
Absolutely. So am I.
So we're very much appreciative of where the department is. We would note that we are really looking for pushing out school-based health centers and hopefully having a growth period. School-based health center numbers have been relatively flat over the past few years. There are 13 jurisdictions with school-based health centers. We think probably every community, every jurisdiction needs school-based health centers. So what we're really looking for is, public health planning and collaboration with community partners to look to see how the school-based health center program can grow. And as part of that, how it can be integrated into the department's child health efforts. Thank you.
Thank you. Next, we have Delegate Shalega, followed by Delegate Bagnall. Delegate Shalega.
Thank you, Madam Chair.
My pleasure.
I have a few concerns. One, I'll mention that we just passed a bill for the Prescription Drug Affordability Board to give them an extension on reporting because of COVID. And I look at these two departments, the Department of Education and the Department of Health, that are very taxed right now with COVID. So my first concern is the effective date on this. I'd rather have them work on getting kids back to school and the Department of Health work on, getting over the pandemic. I don't think the timing is here for doing this right now. And so I'd first ask that if this bill has to pass, if we push the effective date out another year, possibly two. But secondly, in reading their testimony from the bill hearing, it just looks like it might be better to have, and I hate studies and task force and all that, but have a meeting of these two departments, the education and health, and come up with a better solution. And of course, Robin Elliott said that things have been flat. Well, kids haven't been in school for an entire year. So, things have been flat. And, I'm not saying I'm opposed to moving this, school-based health centers forward. I just think we need to take a pause.
Ms. Elliott, what will you say to that?
Thank you for the question, and really appreciate your that perspective. I think what we were thinking of with this bill is because school-based health centers are such an important part of COVID response and then getting back to normal after COVID, that we really want the school-based health centers to be situated and fully integrated into the department's response and the state's response. So the timing their existing guidelines, those could be easily moved over. Nothing has to be done right away. And the timing of the report back to the General Assembly has to do with aligning it with the budget cycle. There's a small grant program now under MSDE, depending on, I know there was Kerwin legislation introduced yesterday. I haven't read it, but there is funding in there that would come at some point to hopefully augment school-based health centers and get them in more jurisdictions.
And we could essentially, Madam Chair, send a letter and ask the Department of Health and the Department of Education to work together to come up with a solution to this, problem that's been highlighted by the bill, and then take it up next year. That would be my suggestion.
Any other questions, Delegate Shalega? Thank you. Delegate Bagnall.
Thank you, Madam Chair, and thank you to the advocates. I guess I'm wondering, because we were prescriptive in the bill about the Bureau of Maternal and Child Health, that there was clear intention in that, and I don't believe that was by accident. So if someone could speak to how that is a resource that we could utilize in, with immediacy, because I do believe that, especially post-COVID, we need to expand our school-based health centers, and we need to do it with great immediacy and efficacy.
So Delegate Bagnall, and I can answer, if the chair would like, I can answer that question. So Delegate Cullison is the bill sponsor in the House side, of course, and Senator Lamb on the Senate side. They both sit on, there's a school-based health center council that actually Mr. Luckner, it's under his commission. And so they've been working on school-based health centers for, I think, about 4 years. And so when they looked at all that was going on within the department and where the programs were aligned, it was actually, they discussed putting it in the Bureau of Maternal and Child Health. One of the things they talked about is potentially tapping into some of the federal money that comes into that bureau. And, that just might naturally align the department's work. And that there could continue to be coordination with other parts of the department in MSDE, but that the home they thought really resided where the children's health issues are, because that's what they're in my talking to them, that's what they relate to me.
Thank you.
I know Ms. Pam Casemeyer wants to be heard.
Sorry, my video wasn't working very well.
It's okay,
So
it
I
happens.
just wanted, Pam Casemeyer, I'm here speaking for the Academy of Pediatrics and the Federally Qualified Health Centers, who also are very actively involved with the council that Robin made reference to, and just wanted to support the recommendations of the council, which which are incorporated in this legislation. And I can't add substantively any more than Robin has done, but I just wanted to add the additional support of those organizations for this initiative.
Thank you. Chu, Ms. Chu?
Oh, great. Thank you so much.
Okay.
Hi, everyone. My name is Dr. Shelly Chu. I'm actually the director for the Bureau of Maternal and Child Health. And I work very closely with Dr. DePinto as well. And I just wanted to give some context about the Bureau. And I started with the State Health Department back in July. And so really have been just grateful for the opportunity to be working with Maryland families, and I've met just wonderful, wonderful colleagues. So with the Bureau of Maternal and Child Health, yes, we do work with very closely with families, and we take the life course approach as well. And but we do own a lot of that maternal and child health programming. So that includes, for instance, the Maryland Family Planning Program, our maternal, infant, and early childhood health programs. We help run the child fatality reviews, fetal and infant mortality reviews. I will say that as it relates to all the topics within maternal and child health, we do collaborate closely. So for example, with asthma, we work closely with the Bureau of Environmental Health. We also work with Dr. DePinto as well. And then we also work, for example, for immunizations, we do work with our other offices and other bureaus within the Maryland Department of Health. I think it says more to sort of how much work needs to be done. And this is something that we can't do alone. And so we need to rely on our partners. As it relates to school health, we do work very closely with Dr. DePinto and her team. And then, there was mention of federal funding as well. And so we do work with Title V and work specifically with our local health departments for administration of grant funds. But as it relates to school health and sort of the management and the guidelines that Dr. DePinto had discussed about, that really does run with Dr. DePinto's in the Office of Population Health Improvement as well. So I just wanted to provide that context. And then from our perspective, I think when we think about programming and implementation, it would be something new and new infrastructure within our Bureau that we would have to stand up. And so it would be something new. And I think, with the infrastructure that Dr. DePinto has already put together, I do wish also so that there wouldn't be fragmentation in terms of where programs sit. I think it's still on our end, we would definitely, most certainly be collaborative as we do with all other programs and initiatives as well. Thank you.
Delegate Rosenberg.
Thank you, Madam Chair. I would just make the point that if we send this to a study, it delays for 1 year the provision of healthcare to students. And I think the pandemic shows that telehealth is essential, and therefore I think we should move forward with the bill. Thank you.
Delegate Terry Hill.
Thank you very much. This may be for Drs. DePinto and Dr. Chu. So for several years now, 4 or 5 years, I know I've been working, Delegate Cullison's been working, Senator Lamb's been working on trying to get a right fit in our school-based health generally, where right now the State Board of Education and the Department of Education takes the lead as if this were about school issues and the health were secondary, when in reality, this is a healthcare issue, and the schools just happen to be the geographic location where it's being provided. And so where it is in the department, it's going to be a lift anyway to get this right fit. We've had meetings with public health people. We've had meeting with the superintendents for different kinds of bills over the last several years. And the issue is always, no one has the staffing or the money to do what seems to be right, which is to transition school-based health to be primarily under the Department of Health and not primarily under the Department of Education. So that is what seems to be significant about this legislation. And I would suggest that if it's an issue of not having enough manpower, I mean, it doesn't sound, there's going to be coordination either way. So I'm not hearing where it's a separation or a loss of coordination. It really is manpower. And that's a separate issue. And that has to do with whether we can capture the federal funds or whether we actually have to create another pin in the proper department. So the question to the two of you is, am I misunderstanding this? I mean, this bill to me begins to put healthcare for students in the right place, which is under the Department of Health. And I think, as the bill sponsor has argued, the fit with maternity and child health, despite the fact that we always think about that as, kids under the age of 5 or 6, that is the most natural fit. And the lift's going to have to be done either way. So that's the question. Am I wrong about that?
Thank you, Delegate Hill. Next, we have Delegate Chisholm, followed by Delegate Riley.
Thank you, Madam Chair.
My pleasure, Delegate.
Thank you. I'm now confused about something that Delegate Rosenberg said. There's a $9 million in grant that is supposed to be transferred now from MSDE to the school-based health centers. But that $9 million is not being cut off by this bill. The same amount of funding would still be going towards school-based health centers, but it's just still underneath of MSDE and MDH at this point without the bill. Am I correct on that? Or
Delegate Pena-Melnick, would you like me to answer?
Absolutely. I'm sorry, I was muted.
So Delegate, you are correct. What we're really hopeful is for that additional fund. There's $2.5 million that has been in MSDE for, I don't know how long, over 10 years, funding a set of school-based health centers. What we're really looking for is when that infusion of funds comes in, and I'm not sure of the date, I think it depends on what you all do with Kerwin, but when that comes in, that it's really used in a public health needs assessment manner, where really the department takes a look at which communities have a need and really partners with those communities to develop school-based health centers that have the services that are needed for their communities. So in some cases, a community may have a lot of access to dental services and others they may not. So really school-based health centers are designed to be a partnership between the state, but really community-led, because it's about what shortage exists in that community. And so really that classic public health approach to how we do public health planning, that's what we're really hopeful for this bill.
So it's your opinion that
One second, Ms. Pinto, I have to call on you. Let the delegate finish and then I'll call on you.
Because the question is more for Robin Elliott, I guess. So it's your opinion, fact or not, that at this point, MSD and MDH are not implementing it in a way that you feel is effective, and you feel like the grant money going somewhere else would be better used, I guess is my question for you.
Yes, that is my viewpoint, or the viewpoint of several of my clients. So,
okay, thank you.
Mr. Pinto, you may speak.
Hi, thank you very much. I apologize.
My pleasure, my pleasure. I just have to have certain order, but I thank you for your patience though. Thank you.
I understand completely. So I just also want to respond to the comment that Delegate Rosenberg mentioned, and also what Ms. Elliott mentioned. So first of all, as was already stated, in the absence of a transfer or an absence of a transfer to a specific unit within MDH, the current services as they exist would still exist. Obviously, an infusion of additional funding would give the department, if were the program to come to MDH, it would give us the opportunity to identify other strategic, innovative, and different ways to utilize those funds, different from the way they've been currently being used. In terms of this issue of a community and needs assessments, I just want to also highlight that the Office of Population Health Improvement is an infrastructure support office. It is an office that is heavily invested in looking at data, and our primary care office is the one that analyzes data across the state to identify the areas where there are what's called HPSAs, or health professional shortage areas. And we use school-based health center data as part of that analysis. We are actually currently in our new 5-year cycle around community health needs assessments, which we are currently doing to be able to advocate for additional designations. And so the kinds of work that Ms. Elliott was speaking about are the very ones that are the health services and health systems infrastructure supportive activities that very well align with the need to expand school-based health centers. And so I think that the argument related to that for the program coming to MDH is very, very strong. However, again, I would just like to state that with all of the different types of data that is used within the Office of Population Health Improvement, as well as within the Maternal and Child Health Bureau within the department, is supportive of school-based health center expansion. And the particular unit within MDH that it goes to, I'm not certain if that is necessarily something that needs to be designated for that specific purpose.
We have Delegate Riley. Delegate Rosenberg, your hand is up. Do you have a question? Okay, Delegate Riley.
Thank you, Madam Chair. Actually, Delegate Chu pretty much covered my my question. It was in reference to the grants, and did they feel that where those grants are currently going is not sufficient, and they'd rather move it over to the Department of Health. So they answered that. Thank you.
My pleasure, Delegate Riley. Next, we have Delegate Johnson and Delegate Rosenberg.
Thank you, Madam Chair. I don't believe Delegate Hill's question was answered, and I was interested in that answer.
Okay, what was will you be so kind and state the question again for her, Delegate Johnson?
Actually, Madam Chair, if you'd allow Delegate Hill to ask that question again.
Okay.
It was
All right.
involved
I thought it was
question.
more of a statement, but Delegate Hill, will you be so kind and tell us your question? I don't see Delegate Hill here.
I'm gonna summarize our question then,
Thank
if
you.
it's okay.
Absolutely.
Since it was an access to health care issue, would it not be better suited with the Department of Health?
And who would like to,
That was directed at Dr. Chu or Dr. DePinto.
yes. Actually, why don't we have, let's see, Dr. Chu.
Yes, I think going back to in terms of it's school health, and it is a healthcare issue. I think as Dr. DePinto had mentioned, I think we are supportive of expansion of school-based health services and school health being within the Department of Health. I think when it comes to the specifics, I think we would like an opportunity to discuss and to plan.
Okay. Ms. Chair.
Thank you, Madam Chair. I
My
just to be clear, Delegate Johnson, we're supportive, MDH is supportive of moving SBHCs into our department. Where our concern lies, and I think Dr. Chu kind of hit the nail on the head, is that it's very specific about what unit within MDH it should go to. And we would just ask for a little flexibility to make that determination as we bring the program over and do that coordination. But we are supportive of having SBHCs live within the Department of Health.
All right, thank you. Thank you, Madam Chair.
Any other questions or concerns regarding the bill? I see none. So this is how I see it. School-based health centers basically service, particularly the Black, Latino, low-income children that are likely to experience lower rates of insurance and healthcare disparities. They are often concentrated in high areas of poverty. They're located within the schools, so the parents and the students can have access to make it easier for them. Some of them even provide dental services as well. It seems from the discussion that, especially the last statement by Dr. Chu? By Dr. Chu and Ms. Heather Sheck, that they don't object to it going to the Department of Health, and correct me if I'm wrong, that it actually makes sense. It's just a matter of the timing. I think that the bill is flexible enough and would allow it for these health centers to basically be part of a broader public health initiative, which it really ought to be there. I think that being said, even if I held the bill, I honestly can sit here and say that there's not going to be a meeting of the mind because both parties feel very strongly about it. I think it's a policy decision that this Public Health Committee will make, whether it should be under the Department of Education, that is the broader, bigger issue, or should it be under the Health Department? Now, we all agree that one thing that we agree today is that it ought to be under the Health Department because you're providing health services to very poor kids. And I think that the departments know each other already. They're willing, according to the fiscal note, they're willing to do it, and they can do it with existing resources. It's clearly in there. So holding it is not going to make a difference. Otherwise, I would have, if you could work it out. And that is sort of my read on it. That being said, any other questions or concerns about the statements I just made?
Delegate Collison has joined the meeting.
Yes. Delegate Collison.
Thank you, Madam Chair, and I'm sorry that I've missed the discussion. I just got out of my subcommittee. I would, it sounds to me like there's an inclination to hold the bill. I guess I would.
No, Delegate Collison, I just stated, Delegate Collison, that it would not make any difference to hold it because both parties are very strongly about their position, but that we basically agree that these programs should be under the Department of Health because they service the very poor in very poor area, majority kids of color that need the access, and it should be under health and not the Department of Education.
I can't agree with you more, Madam Chair. Thank you very much. You've expressed my sentiments exactly.
Thank you. That being said, on any other questions? I see none.
Move the bill.
May I have a second? Any questions on the bill as it's been moved? All those in favor say aye.
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 Any opposition? Delegate Chisholm, Delegate Shalega, Delegate Riley. Thank you so much. I want to thank you all for a very respectful dialogue and for being able to clearly, patiently, listen to both parties, to all the parties, okay? Thank you very much. We have next and the last bill of the day is basically House Bill 463.
Okay, this is the Health Equity Resource Act, and this was in subcommittee about a month ago, and we did a walkthrough of the bill as introduced. And since then, there have been amendments. I sent you a reprint of the bill as amended. Now the bill is essentially in two parts. So part one of the bill starts after line 30 on page 3. And this provision would take effect immediately, and it establishes a pathways to health equity program in the Community Health Resources Commission. This part of the bill is effective for 2 years, and the purpose of the program is to provide the foundation and guidance for a permanent health equity resource community program in MDH. And moving forward, I'm going to refer to this as HERC, just for the interest of time. The program will provide grant funding to reduce health disparities, improve health outcomes, improve access to primary care, promote primary and secondary prevention services, and reduce healthcare costs and hospital admissions and readmissions. The Commission will issue an RFP for applicants with proposals for programs that address the above criteria and demonstrate how the program could be sustainable as a permanent HERC. The Commission will also issue 2 reports to the Governor and the Legislature, an interim report on or before January 1st, 2022 on the grants provided, and a final report on or before January 1st, 2023 on the grants provided, options to develop, sustain, and establish a permanent HERC program in MDH, cost-effective ways to measure a HERC, workforce and recruitment strategies to be used by a HERC, and any legislative recommendations regarding the HERC program. The first part of the bill is funded through a Pathways to Health Equity Fund that is in the Commission, and it consists of the $14 million that was authorized for the Commission under the Relief Act. And this first part of the bill would be effective until June 30th, 2023. Now, the second part of the bill starts on page 4. If you look on page 3, line 13, this establishes the advisory committee, and that would be established on or before July 1st, 2021. The Secretary of Health will establish the committee, which will provide assistance to the Community Health Resources Commission in developing the reports that are required under the first part of the bill. The advisory committee would also provide guidance to the Secretary when permanent HERCs are established and would identify long-term funding strategies for permanent HERCs. The advisory committee now consists of 9 members, which consist of representatives of 5 state agencies appointed by the Governor, 1 local health department representative, and 3 subject matter experts. For the first 2 years of the bill, the chair of the Community Health Resources Commission will chair the advisory committee. And after those first 2 years, the Secretary of Health will then appoint the chair. If you move on to page 10, after line 3, the Secretary of Health is required to convene working or advisory groups to facilitate implementation of the bill and must include individuals who reside in an area that has been or may be designated as a HERC. On to page 10, after line 4, this describes the entities that can apply to be a permanent HERC and requires those entities to include FQHCs or other community-based organizations to provide health or wraparound support services. After line 16, this describes what the application may include. On page 11, starting on line 28, beginning July 1st, 2023, the Secretary of Health is authorized to begin to designate HERCs. And if you continue on to page 13, this section of the bill is essentially the same as the bill was when introduced. Now, most of the language starting on page 13 through 23 has been stricken, which means that the tax credits, loan repayment, and the alcohol tax are all out of the bill. And the reports from the areas that are designated of HERCs remain in the bill, and that's on page 16 through 17. And the bill is an emergency bill because the first part of the bill with the $14 million uses Relief Act funding, and that Relief Act was also an emergency bill. So there are several individuals on this call who are interested in the legislation, if you have questions.
So basically, the aim of the bill is to reduce disparities and improve health outcomes in specific geographic areas. The Health Equity Resource Community is it says here, contiguous geographic area that demonstrates measurable and documented health disparities and poor health outcomes is small enough to allow for the incentives offered under the bill to have a significant impact on improving health outcomes and reducing health disparities, including racial, ethnic, geographic, and disability-related health disparities. This is designated by the Secretary of Health, and they must have a minimum population of 5,000 residents. With that being said, members, will you be so kind and raise your little blue hand, and I'll start calling on you. And you have the interlineated copy that Erin was very kind to send to us that makes it easier for you to read and to see the changes. We'll start with the first hand I saw is Delegate Eric Barron, followed by Delegate Chisholm. Delegate Barron.
Thank you, Madam Chair. I just want to remind the committee that the program in this bill is already proven to work. It's based on a previous 4 to 5 year pilot health enterprise zones program between 2011 and 2015. There were 2 separate studies on that pilot, which determined that the investments made actually saved $93 million over the span of that 4 to 5 year pilot. A separate study, both of these studies done by Johns Hopkins University, the second study looked at the health outcomes and found very significant positive health outcomes in the areas designated as health enterprise zones. So I just wanted to remind the committee of that information and that testimony from our hearing. And we're essentially looking at an evidence-based, already proven mechanism to get the most out of the rainy day fund dollars that we've already passed in the Relief Act. Thank you, Madam Chair.
My pleasure. Delegate Chisholm.
Thank you, Madam Chair. I just want to confirm.
My pleasure.
We have taken out the alcohol sales tax that was going from 9% to 10%. And this is just coming from the rainy day fund. Am I correct on that?
That is correct.
Okay, and I'm sorry for not picking it up, but Delegate Barron referenced, we've seen a successful model. I think I understand how this would work. You'd go into like Northeast Baltimore, a nonprofit is awarded the grant, and then they service that community that is in need more than and provide the services there. But when you were referencing a successful model, is there an actual physical model that we could look at? Is that what you were referring to? I think he's frozen.
Delegate Barron?
So I'm not sure what you mean, a physical model, but there were health enterprise zones that were geographically described or determined areas. There were nonprofits and healthcare groups and such that got together, applied for funding, and then, you know, serviced those areas consistent with the funding application. And, you know, the studies determined they were, you know, highly successful, cost effective and successful with respect to healthcare outcomes. You can actually, still on the Maryland Department of Health website, you can find where these prior health enterprise zones were, and look up, you know, the specific plans that they had for their community as examples or models for what, you know, future health equity resource communities might do and look like.
So you would want to model from a smaller scale and just duplicate it and make it larger because I guess the small or the sample you're looking at was successful. We take that and make it a much larger piece. I'm assuming that's correct.
Basically, yes.
Okay, thank you.
Yeah, so I remember one that I know that they were awarded, like, I believe 5 areas, St. Mary's, you have Prince George's County, Arundel County. And I remember the one in Anne Arundel where I was so impressed where they actually took a building, a public housing building that they would make a lot of calls to the police, right? And a lot of the calls were health related. They went into the building, they opened a doctor's office inside the building. They will go door knock on the person's door and say, hey, you have to come and take your blood pressure or check your diabetes or go for a walk. And they reduced the number of calls to like 0. And they came and testified in front of the committee. And that was one of the health enterprise zones where it was very focused on that particular community. That's one that I remember. And then there was the one in St. Mary's as well, I believe, that was extremely successful.
Yes.
Well, so we have Delegate Shalega.
Thank you. Yeah, it's a different bill. I brought the other bill with me and then saw Aaron's rewrite of the bill. So the first line, I should probably know this, but I don't. The commission shall establish a pathways to health. What commission are we talking about?
And Aaron can correct me, but we're talking about the Community Health Resources Commission.
Correct.
Okay. And that already is established, correct?
Yes, they exist, and they're on the call if you have any questions for them. They're
okay.
Directors on the call.
So I like that, Delegate Barron, you put key measures to evaluate the impact of the proposal, you know, because we don't want it to be some nebulous thing that, you know, we're going to make people feel better. That's not measurable. So then it looks like the fund consists of $14 million a year, and you're saying that $14 million is already fenced off from the Relief Act?
Yeah, it tracks the Relief Act, and that's also, that's actually clearly stated in the bill. Under the fund consists of, it's 14 million authorized for the commission under Chapter 39 of 2021. So Chapter 39 is the Relief Act.
Okay, and that's just 1 year though, or is that more?
It's 2 years.
2 years, 14 each year for 2 years?
No, 14 total for 2 years.
Total 7 and 7.
Yeah.
Or however they.
Or just 14 to be used.
14 total, right, okay. And then on page 4, it looks like there's going to be an advisory committee, is that right?
Correct.
Okay, and then on page 5, on line 15, has a minimum population of 5,000 residents. I expressed concerns about that when we talked about it the last time. I mean, that apartment building that Delegate Pena-Melnick talked about wasn't 5,000 people. I'm concerned that we're going to be negating some of our, more rural communities by putting this threshold.
So this part of the bill only applies to the permanent HERCs, not the ones in the first 2 years. But I know there's people on this call that can speak to why they chose 5,000 as a benchmark.
Delegate Shalega, would you like me to find someone on this call?
Yes, I'd like to, because if you're saying the words permanent, I definitely don't want to exclude rural or smaller communities permanently from this program.
Thank you, Delegate Shalega, for your questions. I think that Ms. Spencer is able to address that question. Ms. Spencer, will you be so kind and address Delegate Shalega's question?
Yes, thank you. And thank you for the opportunity.
My pleasure.
Thank you for the opportunity. The 5,000 is a minimum of 5,000. It can be as large as necessary. That includes contiguous areas. However, the 5,000 is a minimum number of persons that should be included within the zone. And for Anne Arundel County, yes, the HEZ was established within that housing building. However, it was in partnership with Anne Arundel Medical Center and other community-based organizations in that specific community. And it included a number of zip codes as well.
I don't think you answered the question though. Why? I'm not worried about the minimum of 5,000. I'm worried that there's communities smaller than 5,000 that will be excluded from this.
I see. So the reason for 5,000 was to ensure that we had a population that was measurable. We could certainly look at matrix that can help us determine if we should be looking at a smaller number, i.e. whatever that number could be based on epidemiology and based on what a specific population or community based, like recommendations for what that number could be. So we could certainly think about what that population metrics could be, that total number could be.
Yeah, I would appreciate that, especially if you look on the shore, Chestertown, some of the smaller communities are not going to have 5,000. Yet, they certainly would be worthy of consideration. And then this commission chair is not getting paid. Is that right, Delegate Barron?
People don't get paid for their membership or whatever, for their.
Okay, so there's not, will there be an executive director that gets paid? Who's going to get, how is that going to work?
You're speaking to the advisory committee?
Or the commission that's going to be.
The commission already exists. This is
okay.
Additional duty for that commission.
Okay. All right. And the last question would be on page 13. It says on lines 15 to 17, a designation by the secretary of an area as a health equity resource community shall have the term of 5 years and may be renewed with an application approved by the secretary. So could that be renewed forever? What is the thought on that language?
Delegate Barron or Vinny would like to be heard?
Yeah, Madam Chair, I just want to go back to the 5,000 for a second and just point out that of the 5 HEZs that were, this 5,000 limit was in the 2012 HEZ law, and 2 of the 5 were rural communities, one in St. Mary's and one on the Eastern Shore. And smaller communities can be combined to make the 5,000. But we think, as Michelle said, the 5,000 is necessary for measuring purposes and getting the data. But rural communities were definitely high on the priority list in 2012 and would be again under this program.
So going back to the question that Delegate Shalega asked regarding page 13, line 15E, where the secretary of an area shall have a term of 5 years and may be renewed. So I guess her question is, can this be indefinitely? Who would like to address that question?
Madam Chair, I think it can be indefinitely, but I think the important thing is that every 5 years, the health equity resource community must submit data showing that it's effective, and that it's up to the secretary to determine whether that data, that what they report shows that they're using the money well, making progress, and they should keep going. So there's no limit, but they have to every 5 years show that they're using the money effectively.
So in other words, if they're not effective, if they're not doing a good job, if there are any scandals or anything, they can be removed.
That was my concern. Okay,
They have to under that language, they have to reapply. So,
Okay. Yeah, I just wanted to clarify it because I just wanted her question to be answered. Any other questions, Delegate Shalega?
not for now. Thank you.
Thank you for your questions, Delegate Shalega. Next, we have Delegate Lewis, Robin Lewis.
Thank you, Madam Chair, for adding my last name when you called me, so I don't get confused again. Thank you so much for this discussion. This is a really important bill, and I think the key to health equity is that it touches every Marylander, not just Black Marylanders or Latino Marylanders, but whites who are poor and rural. And that really is the goal, to lift everyone. With that thought in mind, I'm curious about how the advisory committee will make decisions regarding the grants that they give out, or that they recommend be given out. Could someone talk to me a little bit about the proposal process, the RFP process, and how those decisions will be made?
Who would like to be heard on that? Who's the best, not the best speaker, but who has the knowledge to answer that?
Delegate Lewis, are you talking about the first part of the bill with the Community Health Resources Commission doing grants?
I'm talking about the advisory committee. My understanding is the advisory committee makes recommendations about, or leads the process for evaluating grant applications, and they make recommendations. Who's going to get that money, the grant money? I'd like to know how that's going to work.
That's where I just need clarification. Under the first part of the bill with the $14 million, there's going to be grants provided, 2-year grants. Then the second part of the bill is when you have the permanent program. And is that the part you're talking about?
Where there's solicitations with RFPs?
The first part of the bill will be an RFP. And
that's what I'm at. That's what,
okay.
Yeah, that's what
so
I'm trying
I think,
sorry, I'm not being clear.
It's okay. It's a little confusing. Mark Lechner's on this call, and he's the executive director for the commission. He could probably answer.
Thanks, Erin.
It's good to see everybody from HCO. Thank you very much for the opportunity to be here today. Delegate Lewis, thanks for the question. As Erin said, I work for the Community Health Resource Commission, and what we do is we award grants on a competitive basis via a call for proposal process. And as part 1 of the bill lays out, as Erin, your counsel described, the commission would issue a competitive call for proposal process following the language of this reprint and the language of Senate Bill 496, the Relief Act. We would have an RFP process that would be efficient, transparent, and robust. That's what we do at the Community Health Resource Commission.
And that's standard operating procedure. This solicitation process wouldn't be any different than any other grant program that's implemented, correct?
It would be similar to our traditional standard operating procedures, though we would be following the language of the reprint before you as we draw up the RFP.
Okay. As you develop the RFP, and then the consideration of applications, again, this is all routine. This is what commissions do. This is how you make decisions about grants, who gets the money, correct?
Correct. This is why your committee in 2005 created the Community Health Resource Commission, to award grants on a competitive basis in underserved communities to help improve outcomes, reduce disparities, and reduce avoidable hospital costs.
Terrific. Thank you so much. Thank you, Madam Chair.
My pleasure. I know I have Chris on this call, and I'd like to know what basically, Chris, can add and provide assistance. If you can just describe that to the subcommittee, what your role will be.
Thank you so much for having me, Madam Chair. I'm Craig Bem, the Executive Director for CRISP. So I think our role certainly is at the discretion of the committee and the commission and the advisory committee. But it strikes me that this bill is very similar to some of the other health equity programs, and much of the work that we do and that the Community Health Resource Commission does that is looking for data-driven outcomes. And so I would hope that our role could be to help analyze the data by community, zip code, population, to help understand maybe the most at-risk or at-need communities by specific, whether it's health disparities or socioeconomic status or other things, and then hopefully help monitor how the programs are doing, if they're effective, if they have a good case for renewal every 5 years, et cetera. And then ultimately, if this helps align many of the programs that folks like the Hospital Association and Department of Health and potentially other new health equity commissions are doing because of a common data set and common kind of definitions and functions, I think it could help make all of these different programs more aligned and more effective.
Are there any questions for Mr. Ben? I see none. Anyone that wants to be heard on this bill that came today? Ms. Cavesmeyer, Ms. Elliott. Okay. I don't see anyone. Are there any questions or concerns regarding the bill? Everyone is okay with it?
We have to move the amendments first, correct?
We have, yes. Thank you, Delegate Chisholm. On the amendments, may I have a motion, please?
Motion to move the amendments.
Second. David, moved by Delegate Johnson, second by Delegate Chisholm. On the amendments, any discussion on them? Any concerns? All those in favor say aye. Aye.
Aye.
Aye.
Any opposition to the amendments? Seeing none, on the bill as amended, may I have a motion?
Move the
please?
bill.
Move the bill. Second.
It's been moved and second. Any discussion or concerns on the bill as amended? Seeing none, all those in favor say aye.
Aye.
Any opposition to the bill as amended? Seeing none, the bill passes, is unanimous. Before you leave, I want to thank you. I know it is 12:37. We took a long time, but I know that the discussion is worth it. I want you to get an opportunity to ask your questions and for us to answer them, and if we can't answer them, to find the answer for you. Thank you for the advocates that came today to help us work through this process. For the committee, we're going to be meeting a little more often because, as you can tell, we've been taking our time with the bills as we should, but we do have a lot more bills that we have to get through. So I would really appreciate your patience with us as we move through this process. I hope you get to have a little lunch. You have a little less than an hour. And thank you so much for your questions. Okay, have a great afternoon. Bye-bye.
Thank you very much.
Thank you, Aaron. Thank you for everything.
Great job.
Thank you.